Dr. Sara Adams. She's one of the long-term PGY-IV residents, and I think that one of the students, I don't know if they were the same from when Dr. Cooper just said it at the last go-round, that all the graduating residents in peds and med-peds do a great round. So it's a great source of stress and joy for them, I'm sure. So she's talking about pediatric palliative care, which that's not my area at all, so we'll be excited. And so you have to participate.
I mean, I can't make you participate, but it would be nice if you would participate. All right, good morning. So I'm Sarah, for everybody who didn't work on the floor with me the last couple of days. I'm going to give another few seconds while this connects.
When you're looking down, it's working, but I think that there's a try.
Oh, okay. Apparently I'm not loud enough. I can talk louder.
No, because the other people won't be able to hear you across the
Good job, guys. Drop the mic. That was not an intentional mic drop. Okay. I'm going to go ahead. 16 students are connected. Is anybody else still trying to connect? Because I'm going to start. Okay. I'm going to start class. So my topic is hospice and palliative care for children. I'm Sara Adams. I got introduced. Have objectives that are to define hospice and palliative care as they relate to the pediatric population, to summarize chronic medical conditions that warrant a discussion of palliative care, and to identify skills pertaining to palliative care and hospice that should be acquired by all physicians who handle complex chronically ill patients. I have absolutely nothing to disclose. Nobody gives me money for anything. Why does this topic matter to me? Hospice and palliative care in particular matters to me because I've actually used it with family members. So that's my grandma and my uncle, and they both used palliative care and hospice, and it was a great source of comfort to our families. Why should it matter to you? A few reasons. First off, there actually is an ABP content standard for hospice and palliative care, and the American Academy of Pediatrics says that all residents should be exposed to it in their training, so now you're exposed. Secondly, I don't know if any of the rest of you have had this experience, but I think that some of you probably have. I think that on occasion, because of our discomfort with discussing this topic with patients and our families, and our lack of education about it in some cases, that we sometimes violate our first thing, which is do no harm. Primum non nocere, do no harm, by not offering these options to our patients early enough for them to get benefit from it. I can think of specific cases of pediatric and adult patients that I've taken care of where, for whatever reason or another, no one had this frank and honest conversation with them until the benefits, it was almost too late for them to get the benefits that they needed. And so as physicians and future physicians, I think that this is something that we need to have in the back of our minds, because it's a tool that we have to treat patients that is underutilized and that can dramatically improve their quality of life. And in the long run, I think what's most important to most people is not necessarily how long is your life, but how good is your life. And this is something that helps to make your life more good. So this is our first question. There's going to be an answer question button. I would like to know some of what you guys think palliative care means. I'm going to hide that for a few minutes while people are typing. I'm going to give you a few minutes to type in some things, and then we're going to look at your answers. They will not show, because I knew if I had people raise their hands, nobody would answer any questions. So nobody's going to know it was you. And for anybody who came in late and wants to join, it's joinpd.com, and that code up in the corner is how you can get into it. so we've got a lot of responses. Okay. So managing end-of-life discomfort, aiming to alleviate suffering without trying for a cure, upholding dignity until the end of life, pursuit of happiness, improved quality of life. These are really good answers, guys. Comfort care, end-of-life care, care without goal of cure, specialized care for terminal illnesses, focuses on relieving pain, quality, using transition from life to death, specialized. Okay. So I'm going to go ahead and just end it. We got one answer that's actually the closest to what palliative care is. And it's specialized medical care for patients with serious illnesses that focuses on alleviation of symptoms. So what is palliative care? Believe it or not, palliative care. All right, you two, do I need to put you in timeout? Because I will. Okay. Palliative care is a branch of medicine, pediatrics and adults, that actually people have been doing for a very long time, but sort of became a recognized medical specialty between 10 and 15 years ago. It does deal with people with chronic life-limiting illnesses, but it can be used throughout the duration of an illness, not specifically at the end of life. So that is something that I think is confusing to most people. You don't have to be almost dying before using palliative care to help someone who has a chronic life-limiting illness. So palliative care in general provides relief from pain and distressing symptoms, affirms life, but regards dying as a normal process. Depending on your belief system, everybody dies. Some people may come back. That's up to you to decide. But for the time being, the mortality rate is 100%. Humans die. It's a normal part of life, but especially in this country, we tend to think it isn't, and that we should be able to not die. It doesn't intend to hasten or postpone death. It's a multidisciplinary specialty. So it integrates psychological and spiritual aspects of care, offers supports to family. It uses a team approach. Depending on whether it's adults or children, the teams may consist of different kinds of people. It's applicable in the early course of an illness in conjunction with life-prolonging or even, especially in the pediatric population, intent to cure therapies. So that's, I think, where the disconnect is and where people don't understand. You can use palliative care even if you are doing life-prolonging therapy. It's an adjunctive measure. In the pediatric population, it is active total care of the child's mind, body, and spirit, and it also involves help for the caregivers. It begins when an illness is diagnosed and can continue regardless of whether or not your child is receiving life-prolonging or therapy with intent to cure. It involves a multidisciplinary approach. And in the pediatric population, there are more locations of care involved. So in the adult population, we tend to think of outpatient therapy, maybe home-based palliative care, maybe some in-office visits. For those of us who do take care of adults and go to the VA, they actually have a palliative care clinic where patients can come for outpatient visits with the palliative care team. In children, it can be provided in tertiary care facilities, in community health centers, and even in homes. And it's more common in countries where we have a lot more pediatric palliative care, like Canada. They have a lot more venues for where this care takes place. So here's our next question. Palliative care and hospice are interchangeable terms. True or false? I have 24 people who have to answer. If you don't want to, that's okay. You guys are doing so good. I'm so proud of you. Okay, I'm going to go ahead and stop it so we can just move. So palliative care and hospice are not interchangeable terms, and I think that's where a lot of confusion comes in. So a lot of the answers I got at the beginning, what you really were talking about when you answered that question is hospice, care at the very end of life, care to ease pain, ease suffering, control symptoms while someone is in the active dying process. So I like this because it's a picture, and most people are visual learners. I'm not, but I did this for you guys. So the difference between palliative care and hospice care involves a timeline. So essentially, hospice care is the end stage of palliative care. So if you look at this graph, do I have a, can you guys see if I, yes, okay. So if you look at this graph, we start at time 0 is our diagnosis. That may be birth, that may be prenatally. I'm going to talk about in a little while that actually prenatal palliative care is a burgeoning field. So that's kind of interesting for our pediatric population. So time 0 is time of diagnosis. This is your therapy focus, and this is your timeline. So if you look at it, as your time progresses, you start out with more curative care, or life-prolonging care could even go here. And palliative care, as we go along, as symptoms progress, as we run through our curative or life-prolonging toolbox and we start to run out of tools, becomes more and more prominent to help us manage symptoms, alleviate suffering, and care for our patient holistically. Hospice is generally something that we refer to at the end when we are in the about 6 months life expectancy. Now, does that fluctuate some? Yes. Some people enter hospice. Our best guess is a 6-month time expectancy. It can go longer than that. That doesn't mean they get kicked out of hospice. But hospice is sort of our end game. And we have said, we've tried all the curative care, all the life-prolonging therapies, or we've tried all we're willing to try, and at this point it's doing more harm than good, or impeding our quality of life or our life goals. That's when we transition to hospice. And actually, the yellow line is death, where the yellow starts. And hospice care translates through after a patient dies to continue to provide services to their loved ones, bereavement care for a period of time, which is a wonderful service. So that's, that's the difference. And so a lot of people think that palliative care and hospice are interchangeable. So when you talk with palliative care about a patient, you're saying you're going to die in 6 months, and that's not accurate. And I think that fact in and of itself should allow us to be more comfortable discussing this, because what we can say, to families is, I'm not telling you I'm putting an expiration date on your loved one. What I'm telling you is they have a life-limiting condition, and I can offer services to help make your life better in conjunction with your curative or life-prolonging care. There are 8 domains of palliative care. Structure and processes of care, which has to do with the team. So hospice or palliative care teams are made up of multiple disciplines. If we're talking about the pediatric population, you may have their primary care pediatrician as well as any medical specialists that they need. So if it's a neuromuscular disorder, you may have a neurologist. If it's a metabolic disorder, you have your metabolic geneticists. If it's something like extreme prematurity and all the complications thereof, you may have a whole host of medical specialists. It also involves specially trained nurses, child life specialists, psychologists or psychiatrists, therapists, spiritual guidance, a part of, and we're going to get there, a part of palliative care is spiritual guidance. So it may involve a religious personnel of the patient's choice, depending on what their belief system is. And it also involves kind of where, so the structure and process of care also involves where the care takes place. Is it like in Canada, where they have a fantastic pediatric hospice and palliative care outpatient center where kids who are getting palliative care can come in for however many appointments they need to meet with therapists, art therapists, music therapists, palliative care specialists, and that also has an inpatient option if that's needed, versus here where we have this, we have fewer options where that kind of care takes place, may be a little bit different. Physical aspects of care is the medical stuff. What therapies medically are we getting? What medications are we getting for curative, life-prolonging treatment, and also symptom management? Psychological and psychiatric aspects of care has to do with your mental health. So dealing with a life-limiting chronic illness can be very taxing, not only on the patient, but also on their family's mental health. And so those needs need to be addressed. Social aspects of care. What sort of support system does a patient have? Is it, are we talking about a child who has, a parent that's a pediatrician and, another parent that's a nurse and they're very familiar with medical terminology? Or are we talking about one of our population where the parent may be a single mother with a less than high school education who has to work a minimum wage job to survive? Those things are going to make a difference in what resources this family needs to care for their chronically ill patient. Spiritual, religious, and existential aspects of care is pretty self-explanatory. Many hospices and palliative care, and all palliative care, are supposed to involve some sort of spiritual care, whether that be a chaplain that's sort of non-focused versus a family's personal minister, something like that. Cultural aspects of care. The culture of a patient is very important because depending on the patient's culture, there are lots of different ideas about illness, where it comes from, how you treat it, bereavement, death, grief, but even things like who makes decisions for a parent or for a child. There are cultures in which the parents are not necessarily the primary decision makers for a child. It may be a matriarch or a patriarch of the family. It may be a group of elders of their cultural group. And those cultural aspects of care should be respected and understood to the best of our ability. Care of the patient nearing end of life, that's your hospice care. So hospice is actually just one of the 8 domains of palliative care. And then ethical and legal aspects of care. Like we talked about, who is making decisions? Are we talking about a teenage patient who understands what's going on with them and has a lot more say in what's going to happen to them than a 2-year-old? Are we talking about a young adult? Because one of the aspects of pediatric palliative care is that as our science progresses, our medical treatments progress, there are life-limiting chronic illnesses that people used to die in childhood, and now they're living into their young adulthood, but adult practitioners may not be as comfortable with those conditions, and so they continue to use pediatric specialists. That makes a difference, if we're talking about a young adult versus a child in the legal and ethical aspects of care. So that's, these are 8 domains. We're going to go into them a little bit more in detail in a few minutes. But I kind of want to transition to, who do you think we need to refer for palliative care? Who do you think would benefit palliative care? There are a lot more than you probably think. We're about halfway there, so I'm going to start looking at some of these. We're still talking chromosome anomalies, oncology patients, CF patients, any prolonged diseases, chemo patients, chronic diseases, acute life-limiting diseases, diabetes, cancer patients, TBI, muscular dystrophy, ESRD. Good. So you guys are getting a lot of them actually. somebody didn't want us to see. It's okay, we love you. Metabolic disorders. So my husband uses this in his middle school classroom. So he always makes sure to actually preview what's been typed before he projects it up on the screen, because 7th graders are a little bit less discriminating than this group of people as to what they think is appropriate to put on the screen. So good job. Okay, so we're going to go ahead and move on. So you guys got a lot of them. So there's a host of, and this is just a drop in the bucket. We have, chronic respiratory diseases. So that can involve your lung disease of prematurity. It can involve, chronic uncontrollable asthma. It can involve CF, genetic disorders, extreme prematurity. And some of these cross over a little bit. So extreme prematurity, the complications can involve severe cerebral palsy, intractable seizure disorders, chronic respiratory disease, genetic disorders. So these do sort of integrate some with each other. And you guys can read this. Now, HIV, I included because it's included in a lot of the studies. And there's a lot of debate about it nowadays because of the therapies that we have. We don't have as many children with HIV, and the therapies are so much better that if medications are taken appropriately, you may have an appropriate, same life expectancy as someone who doesn't have HIV. However, I went ahead and included it because palliative care deals with chronic, potentially life-limiting diseases. And it is a chronic, potentially life-limiting disease. It makes you different from your peers. There are medications you have to take. They have their own bad side effects. And they can still benefit from the services involved in palliative care. I want to hop over here just for a second to perinatally diagnosed congenital malformations. So those can be things like complex congenital heart disease, especially if they're attached to other malformations or possible complications, severe diaphragmatic hernias, any of the syndromes, so any of the trisomies that have potential issues. And perinatal or prenatal palliative care specialists are actually becoming a thing. They're typically neonatologists who do extra care, and you can actually start palliative care while a woman is pregnant, to go and to help with therapy, help make plans for when the baby is born. Things like, do we want to resuscitate if the baby is born dead? Do we want, where do we want to help them make a plan, essentially, for what they think is going to give their baby the best chance and be the best for them and their families. And I think that is something that is going to benefit a lot of people, and I was really glad to see that because we see that very frequently in our NICU. These babies are born, they have severe congenital anomalies. The mom or the dad, the family doesn't really understand what's going on, so their instinct is to say, just do whatever you have to do everything. And sometimes doing everything is not the way to do no harm. And so having these sorts of services available to somebody ahead of time to where we know that they've had counseling and understand, not necessarily just from physicians, but from, psychologists, from therapists, from developmental and behavioral people who can explain what this child's life is going to be like, and somebody to help them walk through that process ahead of time. It's really beneficial. So I thought I would just kind of throw that out there because I didn't know that existed, and I thought it was really interesting and that it's really important. What are the most common barriers to palliative care in general? The first is physician discomfort, especially when it comes to pediatric patients. How many of us really like to talk about with our patients, hey, your kid has something terrible and they can die from it. And if they don't die from it, it's still going to affect their life in a way that's going to make them different from all of their peers. It's going to make them, stand out. Who who really likes to have those conversations? Anybody? No. So that is really one of the main reasons that I wanted to give this talk today. So people who know me know that if there's an elephant in a room, I ask it to come sit down and have tea. Other people don't particularly enjoy doing that. It's something that we need to learn to do in a caring, compassionate, kind, honest, and frank way. And that we need to, if we can't become comfortable with it, at least become good at it and learn how to hide our discomfort. Because this is important. These are people's lives. We're their doctors and they trust us. And they need to trust us to tell them the truth about what's going on, especially with their children. Lack of education. There's not a lot of exposure, I think, overall, especially in pediatrics, unless you're in a really big center, at least in this country. You know, I did not find, in my research, I didn't find a huge number of institutions that have huge burgeoning pediatric palliative care programs. It's a growing field, and so I don't think that a lot of, community physicians or even in academic institutions, I don't think people know what to tell people. Lack of resources. Has anybody tried to get a child into a hospice or a palliative care here? How easy is it? It's very difficult. So finding home hospice, we have a lot of people who live in very rural areas who don't necessarily have what they need in the house. You know, they don't have enough family support. So then you're looking for, you want this multidisciplinary team. Does anybody around here have this multidisciplinary team with child life specialists and therapists and art and music therapy and, no, we don't have that, and lack of funding. So hospice services are pretty much universally covered by insurances, Medicaid, Medicare, but palliative care is not as much. And so when you're talking about a child with complex medical conditions, we're already starting to hit our insurance caps just for whatever treatments they're getting, and then we're going to add palliative care services on top of that. That becomes an issue. So those are sort of some of the most common barriers to care. There are people all over the world working on how we can eliminate these barriers. I'm trying to do my little part today. But that's, I think, why these, the biggest reasons why these sorts of services to patients are underutilized. What all physicians should know. So there are consensus guidelines from the National Coalition for Hospice and Palliative Care that were published in 2018 that are approved by the American Academy of Pediatrics and almost all of the adult healthcare conglomerates. They have specific portions that do talk about pediatric care. So it has your generalized palliative care, and then there's a section on how this applies to pediatric patients. And there were pediatric centers that participated in the development. It is 190 pages. I have a copy of it on my laptop if anybody else would like to read it. But my favorite part of it was that it acknowledges the fact that specialized multidisciplinary teams with hospice and palliative care experts are not available in Forest Hill, Louisiana. So there's a section for each domain of palliative care that's what all clinicians should know. Anyone who's going to take care of anyone who has complex life-limiting chronic medical conditions should know how to do these things. And so I thought that it might be useful for us to go over those things briefly so that you should know what to work on. What should we know? What should we be able to do in whatever medical specialty we're going into, because I don't really know of any, even dermatologists take care of people with, pathologists probably, they don't talk to a lot of patients. But other than that, everybody should be able to acquire these skills. So I just want to kind of briefly go over them with you. So the domain structure and processes of care. The first thing is to understand the value of palliative care general principles and practices. And we talked a little bit about that earlier. Recognize common sources of suffering and complete a basic palliative care assessment. You need to know, does your patient qualify for palliative care services? Because even if you are somewhere where you have access to a multidisciplinary team, you need to know who to refer them, who needs to be referred. Physical aspects of care. Assess their functional status, their symptom burden, and their quality of life. That's something that any physician should be able to do. Develop a treatment plan consistent with patient and family preferences and values. And identify and treat symptoms related to serious illness and its treatment. So some of the therapies that we use to treat complex life-limiting or, disorders have their own terrible, awful, uncomfortable side effects. If we're looking at the classic example of a child with cancer, chemotherapies make people feel terrible. And if a child comes here for their chemotherapy, but they live out in the middle of nowhere, it's useful for their pediatrician to know how to help manage some of those symptoms so they don't always have to run back to Shreveport every time they feel yucky. Psychological and psychiatric aspects of care. We need to be able to identify and treat basic psychiatric conditions with both pharmacological and non-pharmacological interventions. Depression is very common in patients, young and old, who have complex medical illnesses, and in their family members. And we also need to understand the common psychological reactions to serious illness, grief, and loss. People grieve. There's actually something known as preemptive grieving or premature grieving. There's a lot of names for it, but basically, patients and families grieve the fact that their child is not normal. Children grieve the fact that they are not going to have the same life as their friends at school. That grief and that bereavement process are very real, and they have nothing to do with the actual death and dying process. And we need to understand and be able to provide resources in our area. If you don't have a palliative care team, develop relationships with psychiatrists, psychologists, counselors in your area who can assist you with these patients. And so that's something that any good clinician should be able to do. Social aspects of care. Identify strengths and weaknesses of a patient's social situation in order to meet their needs. Does a patient have running water in their house? That's a basic thing that we should know about our patients. There are a lot more things we could go into, but that's, those are basic things that we should be able to find out. Understand the social consequences of serious illnesses. There are social consequences, especially for children. No, you can't go to that birthday party today because, you have LCHAT, and if you jump on the trampoline at AirU for too long, you're going to end up with rhabdo and shut down your kidneys. So you need to stay home today. Or yes, you can go to the birthday party, but you can't jump on the trampoline. You have to sit and watch everybody. You have complex chronic seizure disorder. You can't swim in the swimming pool with all your friends at the end of the school party. Those are social consequences of a serious illness, and we need to understand those and be able to counsel parents especially about them. And identify signs and symptoms of caregiver burnout. Have any of you had to care for somebody with a chronic medical illness? It's exhausting, okay? Mentally, physically. If you have an adult-sized child who can't bathe themselves, can't dress themselves, physically exhausting. Identify signs and symptoms of caregiver burnout so that we can get help for those caregivers. Respite care. Can we get home health? Can we get some sort of community resources involved? Because a healthy caregiver takes better care of their patients. Spiritual, religious, and existential aspects of care. We should be able to conduct a spiritual screening and assess for spiritual distress. We should know if our patients have a religious preference and approximately what it is. And are they having some sort of spiritual distress? Is there a parent who feels like God is punishing them for some sin in the past, and that's why their child has whatever they have. Those are things that, yes, therapists can meet, but sometimes, depending on your religious background, your minister may be more helpful. And we need to be able to facilitate those conversations for our patients. And be aware of and utilize available resources for spiritual support. Are there community religious groups that can help? Is somebody the only person of their religion in the city? Can we get a hold of somebody in a bigger town or, in a bigger place and have Skype with them or something like that to arrange that for them? Cultural aspects of care, and I talked about that a little bit earlier. Recognize that culture affects medical decision making. It really does. Things as simple as cultural beliefs about why people have illnesses. And that is sometimes tied into spiritual and religious aspects, and it sometimes isn't. Acknowledge that there are different cultural approaches to illness, grief, dying, bereavement, treatment options, and utilize available resources to respectfully navigate cultural nuances. We are very fortunate that we live in an age where we can Google anything. Unless something super obscure walks into your office, we should be able to figure out at least approximate information about different cultures. Care of the patient nearing the end of life. This is where we're talking about moving into our hospice care. We need to be able to talk comfortably to patients about death and dying, and we need to get comfortable using the words death and dying. Death and dying are concrete words. Passing away, passing on, moving forward. Those are general, and they don't communicate exactly what we're trying to say. If you need to practice, call me. I'll let you tell me I'm dying a bunch of times because you need to get comfortable saying those words. I've been in situations where I was the first person when somebody who has had a chronic complex medical condition for many years, I was the first person to tell them they were dying. I had that experience as a third-year medical student, that I was the first person who actually told a patient, you are dying. And it's something you need to get good at because you might be the person who has to do that. And be the person because just somebody should have done it before you. That's okay. They're yours now. We need to assess and manage physical symptoms common to patients and nearing the end of life. So that involves things like pain, respiratory distress, emotional outbursts, altered mental status, a whole host of things. And we need to know what the hospice criteria are and make timely referrals to hospice so that patients can get the biggest benefit out of hospice care. It breaks my heart when somebody goes to hospice and then they die in 3 days because they didn't get there early enough and they didn't get to experience the benefits with, as the patient and their family members of hospice care. Which involve things like a nurse will come to your house and check on your person if you're worried about them. You don't have to bring them to the emergency room. Social support, medical equipment in the home. We can get hospices can arrange for someone to have a hospital bed at their house. Things as fantastic as that. Ethical and legal aspects of care. So we need to understand the ethical principles most common at the end of life and be aware of scenarios most likely to cause ethical and legal conflicts. So a lot of these are going to mostly be family member disagreements. Mom and dad are divorced. Mom wants to do hospice care. Dad doesn't want to, quote unquote, give up. What do we do? Who is the official decision maker? The child is in state custody. The parent has visitation rights. The state actually is the decision maker. So those are things that we need to be aware of, and we need to know how to access our ethics committees, our legal experts, etc., when needed. Who do we call to help us if we have a child who needs these services and the adults responsible for making decisions for them can't get along? Do your best to facilitate these conversations. On the test, family meeting is always the answer. If like family meeting is an answer choice, that's going to be the right answer. But know when to access your ethics committee, when to call in legal experts who can help you untie these very complicated who actually gets to do this situation. So those are those are things that every physician should be able to do. They take a lot of time, yes, but they're not something that's out of the realm of capability. They're not something that involves having to have a fellowship in palliative care. There's something we can learn to do to help our patients, and to help our patients get the care they need, to give them the best quality of life for whatever length of life they have. I'm about to be done, I promise. I'm going to let you answer this in a minute, but if you look at the research, palliative care improves quality of life, it improves patient outcomes. It also improves healthcare costs overall. It is a wonderful aspect of medicine that I think warrants everybody looking into more. I wish we had more available here in this hospital. I wish our patients had more resources, but we can use what we've got and we can learn to do this. And I think it's important. So that's why I talked about it today, because I think it's important. So I would like to know what the most important thing you guys learned today is, because when you reflect, you tend to remember things. So. If you didn't learn anything, you can tell me that too. I love feedback. You guys can read. I'm just going to kind of scroll through these and see if we like them. Oh, thanks, guys. It isn't just for cancer patients. That's a huge deal, because everybody thinks of palliative care for cancer patients and not other things. Okay. Y'all are sweet. Okay. So I like to give people a minute to reflect at the end, and if you can remember one thing, then that has made me very happy. These were my references. I actually read a lot more, but these were the biggest ones, so those are the ones I put. There's a lot of stuff out there. If you're interested in doing some research, if you actually just go to the AAP's website and type in palliative care and hospice, you'll get like 15 pages of policy statements, articles, links to scholarly research, those sorts of things. So there are resources out there for you to study. Does anyone have any questions? Yes? I can't hear you, I'm sorry.
Did you come across any resources that we can use in our institution?
Like local resources? I did not. I actually talked to our adult palliative care case manager, and she was supposed to send me some information, and I didn't ever get it. So I have sent at least one pediatric patient with hospice before. They went to a nursing home, so I think, and when I chatted with her, she said she knows of a few places in town that on a case-by-case basis will deal with pediatric patients, depending on what sort of support is available. So I didn't do as much research on that as I would have liked. Yes?
It's very good presentation actually. Actually I was in your shoes 2 years ago. I was part of a research project in early involvement of palliative care in chronic pediatric medical conditions, and our pilot project was cystic fibrosis. We presented that in national conference. But the big barrier was the healthcare providers and healthcare personnel. They didn't want to do it because the word So we were looking at the early involvement. So we are not talking about death now. We are talking about how can we help you? How can we help the family to cope up with the situation for these chronic care patients? So we were looking at that. We were in the first cycle of the project. We were able to, like you, we did presentations. And we were able to overcome that barrier with the healthcare personnel. But the biggest barrier we had is from the families. We consulted the other fact, there are many institutions, they have palliative care team. So those institutions have palliative care teams. So the moment we consulted them, they come, the moment they walk into the room, patient's room, the family said no. We don't want to talk about that. So that was the next big barrier. If half of these families refused, then we were able to talk to them again. We are not talking about death now. We are trying to help you cope up with the situation. So, but half of them we were able to, and they benefited from that. So it is very, very important if we can get that resource. And how do that team exist in the hospital? I think it's from some state, the insurance, they approve. But there is also some funding resource. We can get funding to establish that team. That will be very good resource, very good thing to set up that team.
Yeah. One of the articles I read, they actually tried using different words, like different names for it. So instead of calling it palliative care, they'd call it like supportive care. Or, they just, and they did that with physicians and with families. And I thought that was very interesting because it was more like how can I spin this so the first thing you think of isn't death?
Yeah. And second part is hospice, and Dr. Basar, okay, we know that we tried to for one patient. There is nobody in Shreveport want to do pediatric hospice care. No companies, no institutions, nobody want. Adult they have, but nobody want to do in Shreveport. But that is something I think we have to work on.
Especially for very young children. So I think the closer patients get to being adults, the easier it becomes, but especially for very young children, infants, neonates, very young children, it's a problem. Yes.
In your research, did you find models of how to have these conversations? I mean, there were the things of like what to talk about.
Yes, and actually in the consensus guidelines, there are clinical scenarios for each aspect of care that you can go through that are very good. So if you're interested in looking at that, like I said, it's a long document, but if there's one or the other particular domain you want to look at, each one of them has 5 or 6 or 7 clinical scenarios that some of them are like, you have a patient that needs this and your hospital doesn't have it, this is how you get it, this is how, your patient needs this is how you talk to the family, and so those were a really good resource.
Do you know if Catherine and then would help us with pediatric patients if we had that? Palliative care team?
I don't think so, but I didn't ask specifically. I think, they're so new. So we actually have a small palliative team for our adult service now that basically arranges palliative care, hospice care, that sort of stuff to take it off of the social workers for each team. But it's like 2 people. So they're covering the entire adult service. So I don't know how much time they would have to help us with pediatric patients, but it never would hurt to ask them or to ask Jana. Jana and Kamiko are fantastic, and they probably know as much about what we can do for kids.
Kamiko came to us from the adult services.
Yeah, she came from the ICU. I miss her.
A whole lot more about what's available in the area.
We were very sad when she left the MI.
So especially for your teenagers, there's a lot out there that we didn't realize that we could utilize, but now that we've got Kamiko, she's brought some of those adult services into the kids world.
So it's about time, but I hope I haven't depressed everybody's morning. I think this doesn't have to be sad. It can actually be very happy because you're helping people and getting them what they need. So go forth and save lives.
Thank you.